Welcome back to the deep dive. Today, we are shifting gears a little bit. Usually, we take a sort of casual stroll through a topic, but today calls for a different kind of energy. I want you to imagine the fluorescent lights humming, the uncomfortable wooden chair.
And that stern face of an external examiner staring you down.
Exactly.
Yeah.
We are doing a high-stakes prep session.
It sounds stressful, but for our listeners, and I'm talking specifically to the postgraduates getting ready for their MD anesthesiology exams, especially those at Gujarat University, this is the reality, isn't it?
It is. So for the next 40 minutes or so, I'm stepping into the shoes of that MD postgraduate student. I've got the caffeine shakes, I've got the anxiety, and I have a desperate need to structure a perfect answer. And you are playing the role you were basically born for, the senior MD anesthesia faculty.
Well, I'll do my best to be the benevolent mentor, not the intimidating interrogator. But you're right, we need to be rigorous. We're covering a topic that is, it's a favorite for the long question paper. That's a solid 20 marker. And it's absolute gold dust for the Viva Voce because it tests everything.
Everything how?
I mean, it's physiology, pathology, pharmacology, crisis management, all wrapped up in one incredibly high-pressure scenario.
And the topic is, well, it's the obstetric anesthetist's worst nightmare: amniotic fluid embolism, or AFE, and cardiopulmonary resuscitation in pregnancy.
A classic. It really tests your ability to think on your feet and your deep understanding of complex physiology.
Yeah.
So we're going to build this on the heavy hitters: Miller's Anesthesia, Morgan and Mikhail, the Oxford Handbook, and some key ICU protocols you need to know.
Okay, so our mission is clear: structure a perfect 20-mark theory answer, and just as importantly, prepare for those Weber traps.
Let's do it.
So let's open the books. Part A, amniotic fluid embolism. Professor, if I see this on my exam paper, how do I begin my introduction without just sounding generic?
You start with precision.
Yeah.
You define AFE as a catastrophic obstetric emergency.
Okay. Catastrophic.
Yes. It occurs when amniotic fluid, fetal cells, hair, or other debris enter the maternal pulmonary circulation. But, and here's your first aha moment for the examiner, you must immediately pivot. You should mention that many experts now prefer the term anaphylactoid syndrome of pregnancy.
Right. Because embolism implies a simple blockage, like a clot, or maybe air, but this is so much messier.
Precisely. If you just describe it as a mechanical blockage, you sound like you're stuck in the 1950s. The current understanding, which is supported by sources like Miller's and those ICU protocols, is that this is a biphasic immune-mediated reaction. That's much more like severe sepsis or anaphylaxis. The amniotic fluid itself contains pro-inflammatory mediators, things like prostaglandins, leukotrienes, tissue factor, that just trigger a massive cytokine storm.
I want to get deep into that mechanism in a second, but let's stick to the intro for just a moment longer. Incidence and mortality. I need some numbers to throw at the examiner.
Right. The incidence is, thankfully, very rare. Depending on which registry you look at, it's anywhere from 1 in 8,000 to 1 in 80,000 deliveries.
So it's rare, but high impact.
Very high impact. The mortality is the headline here. Historically, we taught that mortality was upwards of 80 to 86%.
That is absolutely terrifying.
It is. Now, newer data suggests it might be a bit lower, maybe in the 20 to 60% range. And that's likely because we're better at recognizing and including milder cases now.
Okay.
However, for the exam, you acknowledge that high historical mortality to really emphasize the gravity of the condition. And here's a crucial Viva point. About 25% of these deaths happen within the first hour of symptom onset.
The first hour?
Yes. This is a drop-and-die scenario.
Okay, so my opening statement is something like, sudden, profound, unexpected collapse in a previously healthy proturian. That frames it. Now, let's unpack part 2 of the outline. Etiology and pathophysiology. You've labeled this as very high yield.
This is where you earn your marks.
Yeah.
You have to explain 2 things: how the fluid gets in and what it does when it gets there.
Okay, so the how.
The how is a breach. There's a pressure gradient that allows fluid to enter the maternal circulation, usually through endocervical venous lacerations during labor, maybe uterine rupture, or at the placental separation site.
So the fluid gets into the maternal venous system, it travels to the lungs, and this is where we have that old mechanical versus the new immune debate, right?
Correct. The old theory was that fetal debris, squamous cells, the lineage hair, vernix, that this stuff physically plugged up the pulmonary capillaries.
A simple plumbing problem.
A plumbing problem, exactly. And while there probably is some mechanical obstruction, it just doesn't explain the profound cardiovascular collapse that happens so instantly. That's where the anaphylactoid theory comes in.
I want to really flesh this out because the critique of that mechanical theory seems important. Why exactly did the medical community move away from it?
That's a great question, and understanding this is critical for why our treatments are supportive, not curative. Originally, when AFE was first described back in the early 20th century,
Steiner and Lushbaugh, I think.
the very same. Pathologists found fetal debris in the maternal lung vessels at autopsy. We're talking squamous cells, mucin, lanugo. So it was logical to assume debris blocks vessel, heart stops, like a massive thrombotic pulmonary embolism.
It makes visual sense. A clogged pipe.
It does, but clinically, it just didn't add up. As we gathered more and more data, we found that the volume of debris found often wasn't nearly enough to cause such a sudden total collapse.
Okay.
And also, the symptoms looked remarkably like anaphylactic shock bronchospasm, flushing, massive vasodilation happening alongside the heart failure. This led researchers to look at the biochemistry of the amniotic fluid, not just the bits floating in it.
So the fluid itself is almost toxic to the mother.
In a way, yes. Amniotic fluid contains very high concentrations of arachidonic acid metabolites, specifically leukotrienes and prostaglandins. When these hit the maternal circulation, they cause intense vasoconstriction in the lungs.
Causing that phase 1 RV failure we mentioned.
Exactly. But they also cause systemic effects. Plus, there's endothelin, a hugely potent vasoconstrictor. This chemical cocktail causes what we call pulmonary, systemic, and even coronary vasospasm.
Coronary vasospasm, too.
Yes. And think about the implications of that. The heart muscle itself is being starved of oxygen right at the moment it has to work its hardest against that massive pulmonary hypertension.
That explains why the heart fails so incredibly fast. It's not just a clogged pipe in the lung. The heart muscle itself is literally being strangled.
You've got it. And that brings us to that crucial biphasic hemodynamic response. You have to be able to explain this.
Okay, so phase 1, this is the first, 30 minutes?
Roughly. It's that intense pulmonary vasospasm we just discussed. That leads to acute pulmonary hypertension. The pressure in the lungs skyrockets.
And the right ventricle can't handle it.
It just can't push against that wall of pressure.
Yeah.
So you get acute right ventricular or RV failure.
Which leads to hypoxia and hypotension.
Exactly, the initial collapse. Now, phase 2 is what happens if the patient survives that first hit. Then they develop left ventricular LV failure and pulmonary edema.
Why does the LV fail later? Is it just burned out?
There are a few reasons. One is purely mechanical, the septum. The right ventricle balloons out because it can't push blood into the lungs. This ballooning RV pushes the interventricular septum into the left ventricle.
That's the D-shaped septum you sometimes see on an echo.
Exactly. And this compresses the LV so it can't fill properly. If the LV can't fill, it can't pump. It's a mechanical interaction called interventricular dependence.
Right.
But later on, the LV also fails because of that initial hypoxia. It was starved of oxygen during the coronary vasospasm and potentially from direct myocardial depressant factors that are in the amniotic fluid itself.
And all of this leads to the pulmonary edema we see in survivors.
It does. And running in the background of all this hemodynamic chaos is the hematological nightmare, DIC.
Disseminated intravascular coagulation.
The amniotic fluid is rich in tissue factor. It activates factor X and the complement system. You get these widespread microthrombi, little clots everywhere, followed by a total consumptive coagulopathy.
So the body uses up all its clotting factor.
All of them. Basically, the blood loses its ability to clot. So you have a patient who is collapsing, whose heart is failing, and who then starts bleeding from literally everywhere.
It's a perfect storm. Okay, moving to part 3, clinical presentation. We have the classic triad. If an examiner asks me, how does this patient present? What's the bulletproof answer?
The triad is hypoxia, hypotension, and coagulopathy.
So specifically?
Specifically, you'd say sudden onset dyspnea and cyanosis, followed by profound cardiovascular collapse and shock, and then massive hemorrhage. But there's a fourth element you absolutely must mention.
Which is?
Neurological symptoms.
Seizures.
Yes. Tonic-clonic seizures occur in up to 50% of cases. Very often, the patient might just say, I can't breathe, or express a feeling of impending doom. That's the prodrome, and then they seize and arrest.
That premonitory signs point seems like a really specific detail that could impress an examiner.
It absolutely will. The literature describes patients feeling this sudden, intense anxiety, agitation, or even saying, I'm going to die, just moments before the collapse.
Wow.
Other signs can be chills, shivering, or vomiting. If a woman in labor suddenly becomes extremely agitated and can't breathe, your alarm bells should be screaming. It's often mislabeled as just panic or distress from pain, but it's physiological.
Timing-wise, this is usually happening during labor, correct?
Most commonly during labor, yes. But it can happen during a C-section or in the immediate postpartum period, usually within about 30 minutes of delivery.
Okay.
If a patient collapses 2 days later, it's probably not AFE. You should be thinking more about a pulmonary embolism, a PE, or maybe sepsis in that case.
Got it. Now, part 4, diagnosis. This is a tricky one. I remember reading about the fetal cell trap.
Ah, yes. The classic Viva question. The examiner might ask, you have a central line in, you aspirate blood from the pulmonary artery, you send it to the lab, they find squamous cells. Is it AFE?
And the instinct is to immediately say yes.
And you would be wrong, or at least on very shaky ground.
Why?
The sources, Miller's in particular, indicate that squamous cells can be found in the pulmonary circulation of completely normal pregnant women.
So it's not specific.
Not at all. The placental barrier isn't a brick wall. It's more like a sieve. Small amounts of fetal material transfer into the maternal circulation routinely during labor. But because they don't trigger that massive immune response in most women, they're just cleared asymptomatically.
So finding the cells just means this woman is pregnant.
It means this woman is pregnant, not this woman has AFE. It is not diagnostic.
Okay, that's a huge point.
It is. AFE is a clinical diagnosis. It's a diagnosis of exclusion. You treat the patient, not the microscope slide.
So we rely on the Society for Maternal Fetal Medicine criteria: sudden arrest, DIC, onset during labor, and the absence of other explanations, like a total spinal or a massive air embolism.
Exactly. Do not wait for a lab test. If the clinical picture fits that triad, you treat for AFE.
Speaking of treatment, let's go to part 5, anesthetic and ICU management. This is the what do you do question.
It's an emergency, so you revert to your training, ABC, airway, breathing, circulation, but with some very specific modifications for AFE.
Okay, let's start with A, airway.
Secure it early. Give 100% oxygen. If they're seizing or hypoxic or their conscious level is dropping, you intubate. But you have to remember the airway in pregnancy is often edematous and difficult.
And B, breathing.
Ventilate. But you need to watch for ARDS, acute respiratory distress syndrome, which can develop incredibly rapidly in these patients.
Circulation. This is where I feel like I might trip up. Do we just flood them with fluids?
Caution is the key here. This is where understanding that biphasic pathophysiology really matters. In phase 1, the RV failure, you might think they need volume to push through that resistance.
Right.
But you have to remember, phase 2 is LV failure. If you aggressively over-resuscitate with fluids, you will literally drown the patient in pulmonary edema when their LV fails.
So if the RV is failing, overfilling it just dilates it more, which worsens that septal shift we talked about, and that further crushes the LV.
Precisely. The sources, especially the ICU protocols, recommend a much more restrictive fluid strategy. You use vasopressors like norepinephrine to keep the blood pressure up, not just liters and liters of saline.
You're supporting the pressure, not just the volume.
You're supporting the ventricle. Norepinephrine is standard to maintain perfusion pressure, but often you'll need inotropes as well.
Like Dobutamine or Milrinone.
Yes, you might need something like that to actually help the heart contract, especially if there's significant ventricular failure on echo.
And the sources also mention inhaled nitric oxide.
Yes, as a selective pulmonary vasodilator. It's a sophisticated answer for a postgraduate. It helps offload that failing right ventricle without dropping the systemic blood pressure.
And for the coagulopathy, the DIC.
You have to treat the DIC aggressively. The phrase to remember is feed the fire.
Meaning?
Activate the massive transfusion protocol immediately. Get ahead of it. Early use of FFP, cryoprecipitate, and platelets. You don't wait for the lab results if they are clearly bleeding from IV sites and the incision.
And the ultimate resuscitation maneuver in all of this.
Delivery. You must empty the uterus. It's part of the resuscitation. It dramatically improves venous return and oxygenation. Often we are doing a cesarean section while doing CPR.
Which bridges us perfectly to part B of our outline, cardiopulmonary resuscitation in pregnancy.
This is a distinct but obviously overlapping topic. You might get a standalone question just on CPR in the pregnant patient.
Right. So part 6, the exam framing. We have this concept of the dual patient.
Yes, but the priority is singular. Resuscitating the mother is the absolute best way to resuscitate the fetus. You cannot save the baby if the mother's pump has stopped working.
So why is it different? Why can't I just run a standard ACLS gun?
Because pregnancy alters physiology in ways that actively fight against standard CPR. And this leads us straight to part 7, the physiological challenges. The single biggest enemy is aortic valve compression.
The gravid uterus compressing the inferior vena cava and the aorta?
Correct. And let's put some numbers on it to make it stick in your head. At term, the uterus gets about 700 to 900 milliliters of blood per minute.
That's a huge amount.
It's a huge shunt. When the patient rests, that flow continues, but it's useless. Plus, the heavy uterus, the baby, the fluid, the placenta can weigh 6 to 8 kilos. It sits directly on the IVC when she's supine.
So when you do chest compressions...
You are trying to squeeze blood out of the heart.
Yep.
But if no blood can get into the heart because the IVC is squashed flat, you're pumping an empty heart.
And during cardiac arrest, chest compressions only generate about 30% of normal cardiac output at best. If you add caval compression to that, you're generating almost zero flow.
That is the critical concept you must convey, and then you have the respiratory changes on top of that.
Right. The pregnant woman is an oxygen consumption machine. Consumption is up 20 to 30%. Yet her functional residual capacity, her FRC, her oxygen tank, is reduced by 20% because the diaphragm is pushed up.
Which results in incredibly rapid desaturation. You stop breathing, and your oxygen levels plummet in seconds, not minutes.
Okay, this all leads directly to Part 8, modifications of CPR. This is marked as absolutely essential for the exam. If you miss this, you fail the station.
Without a doubt, the golden rule. Left uterine displacement, or LUD, you never, ever resuscitate a pregnant woman flat on her back.
Now, how do we actually do this? Do we tilt the whole operating table?
In the past, yes, we used to say tilt the table to the left. But think about the physics of that. If you tilt the table 30 degrees and then try to do effective chest compressions, you're either going to slide off or your force vectors are all wrong.
So what's the current standard?
Manual uterine displacement.
Can you describe that technique? I want listeners to be able to visualize exactly where their hands should go.
Absolutely. One rescuer, and this is their only job, stands on the patient's left side. They use two hands to reach across the abdomen, hook the uterus, and physically pull it up and toward them to the left.
Or they could stand on the right and push.
Yes, they could stand on the right and push the uterus to the left. The goal is to physically lift that 6 to 8 kilos of weight off the big vessels in the retroperitoneum.
And all while keeping the patient supine on the board?
Yes. The backboard and the chest compressions work best when the patient is flat. The patient stays flat, the uterus is displaced. That is the modern standard.
That's a really crucial distinction. What about hand position for the compressions themselves?
Because the uterus pushes the diaphragm up, it also shifts the heart and the mediastinum. So you should place your hands slightly higher on the sternum than you would for a non-pregnant adult.
And the airway.
You secure it early, but you use a smaller endotracheal tube, a 6.0 or maybe a 6.5 millimeter, because of all the laryngeal edema and capillary engorgement. The tissue is friable, it bleeds very easily. It is a predicted difficult airway.
So an expert tip for the exam. Have a smaller tube ready, use a video laryngoscope if you have one, and pre-oxygenate aggressively.
Aggressively. You have to remember that FRC reduction, a pregnant woman in labor, desaturates extremely fast. You don't have the 3-minute buffer you might have in a non-pregnant patient. You might have 30 seconds before her saturations drop below 90%.
Wow. Okay, moving on to Part 9, advanced life support. What about drugs and defibrillation?
Defibrillation is safe. The current doesn't significantly harm the fetus. Do not delay a shock. If there are fetal monitors attached, get them out of the way if you can, but don't waste time doing it. Shock the patient.
And drugs. Epinephrine, amiodarone.
You use standard ACLS doses. There's no modification for the drugs themselves. However, you have to think about where you're giving them.
What do you mean?
If you have IV access in the femoral vein, and that uterus is compressing the IVC, that drug is not going to reach the heart.
So it's just pooling in the legs.
Exactly. You must use access above the diaphragm, an internal jugular line, or even just large bore IVs in the upper limbs.
That's a great practical pearl. Okay, now for the big one. Part 10, Perimortem Cesarean delivery, also known as resuscitative hysterotomy.
This is very high yield. You must know the 4-minute rule.
Walk me through it.
If you have a cardiac arrest in a pregnant patient who is more than 20 weeks pregnant, and you do not get return to spontaneous circulation, or ROSC, within 4 minutes of starting CPR.
You start the incision.
You start cutting, and you aim to have the baby delivered by minute 5.
The 5-minute rule. Now, the rationale, I assume the student answer is to save the baby.
And the expert answer is not primarily. This is for maternal salvage.
Okay, explain that.
Emptying the uterus immediately relieves that aortocaval compression we've been talking about. The literature says it can improve venous return and cardiac output by up to 25 to 60%. It makes your CPR effective.
So it's a resuscitation procedure? It's like putting in a chest drain for a tension pneumothorax. You're fixing the mechanical problem that is preventing the heart from restarting.
Precisely. You fix the physiology. And it's based on what we know about anoxic brain injury. Irreversible brain damage starts to occur after 4 to 6 minutes of no blood flow. If you haven't got a pulse by minute 4, your standard CPR isn't working. You must change the physiology, and you do that by delivering the baby.
And a key point, don't move the patient.
No. Do not waste time trying to transport them to the OR. You do it right there. In the labor room, on the floor, wherever the arrest happens. All you need is a scalpel and a splash of antiseptic. Speed is everything.
What about anesthesia?
If she's arrested, she doesn't need anesthesia. You are doing CPR. You intubate and ventilate. If you get ROSC, which often happens the moment you empty the uterus, then you worry about providing anesthesia.
Okay, let's bring it all together now. Part C, integration of AFE and CPR.
This is the real world.
Yeah.
A patient with AFE often arrests. So you are running a code blue. You are doing manual uterine displacement. You're intubating with a small tube. You're at minute 4, so the obstetrician is cutting for the C-section.
But wait, AFE causes DIC.
Exactly. So as soon as you cut the uterus, because of the coagulopathy, she bleeds torrentially. It's a bloodbath. You must be activating the massive transfusion protocol at the same time.
So you're fighting pump failure, hypoxia, and exsanguination all at once.
All at once. It's one of the most challenging scenarios in medicine.
I want to highlight that bleeding again. If we do this C-section and the cause is AFE, that uterus is going to be atonic, isn't it? The blood just won't clot.
That's right. AFE is strongly associated with uterine atony. The muscles just won't contract to clamp down on the bleeding vessels. So you deliver the baby, and the uterus is just a boggy sac pouring out blood. You need uterotonics immediately, oxytocin, ergometrin, carboprest, and you need that massive transfusion pack open and running.
Feed the fire.
You got it. FFP and cryoprecipitate are absolutely crucial here because fibrinogen levels plummet in AFE. You have to replace the clotting factors, not just the red cells, and tranexamic acid is key.
It sounds incredibly intense. The post-resuscitation care, part 12, must be just as complex.
It is full ICU-level care. You're managing ARDS with lung protective ventilation. You're supporting the heart, which is likely in the LV failure phase now, and you're guiding that with echocardiography. You're continuing to correct the coagulopathy.
And possibly therapeutic hypothermia.
You might consider targeted temperature management for neurological protection, yes, but you have to balance that very carefully with the significant bleeding risks.
ECMO is also mentioned in the sources.
Extracorporeal membrane oxygenation. If the heart, either the RV or the LV, has completely failed, but you think it might recover, since the AFE reaction is often temporary, ECMO can take over the work of the heart and lungs for a few days.
A bridge to recovery.
Exactly. If your center has ECMO capabilities, you should be calling that team very early in the resuscitation.
Okay. We've covered the content. Now let's move to Part D, exam integration. How do we pass the VIVA?
Comparison is a great way to show your understanding. Part 13, comparing AFE with other causes of collapse.
Let's do a quickfire differential. This table is very high yield for a written exam. Let's build it. AFE versus a total spinal.
Okay, total spinal. You'll have a history of an interaxial block. You'll see apnea, hypotension, dilated pupils. But critically, usually no primary coagulopathy at the start. AFE has that coagulopathy.
AFE versus eclampsia.
Eclampsia usually has a history of hypertension and proteinuria before the seizure. AFE presents with hypotension after the collapse. So while both can seize, the blood pressure trajectory is completely different. AFE is a crash, eclampsia is a spike that then leads to a crash.
Good distinction. AFE versus a thrombotic pulmonary embolism.
A thrombotic PE might have signs of a DVT or preceding chest pain. It causes RV failure, sure, but it doesn't usually trigger that immediate massive DIC that is the hallmark of AFE. And your ECG might show S1Q3T3 or RV strain more typically.
The placental abruption.
That's painful bleeding. A rigid, woody uterus.
Mm-hmm.
The collapse there is primarily due to hypovolemic shock.
And finally, to summarize AFE in that comparison.
Collapse is sudden. The triad is hypoxia, hypotension, and coagulopathy. And it's a diagnosis of exclusion.
That table alone feels like it's worth 5 marks.
Easily.
Professor, before we wrap this up, I want to go back to the VIVA traps in Part 14 one more time. What is the one thing that annoys examiners the most?
A lack of structure. If they ask you, manage this patient, and you just shout, cut the uterus, before you've said, call for help, assess airway, start CPR, you will fail.
Safety first.
Safety first. Structure first. You say, I would immediately call for help, activate the code blue team, ensure left uterine displacement is being performed, and then assess the airway.
Mm-hmm.
That is the music the examiner wants to hear.
And the true embolism trap we talked about.
Just don't get into an argument about it. If the examiner is old school and calls it an embolism, you can just nod. But in your explanation, you should use phrases like immune-mediated reaction or anaphylactoid physiology. It shows you've read the modern texts, like Miller's 9th or 10th edition, without being disrespectful.
So diplomacy is part of the exam, too?
Indeed it is.
Part 15. Diagrams. If I'm writing the long answer, what should I draw?
Draw the pathophysiology flowchart. A simple one. Box 1, amniotic fluid entry, arrow to mediator release, then branch out. Branch 1. Pulmonary vasospasm leads to RV failure. Branch 2. Tissue factor activation leads to coagulopathy. Branch 3. Myocardial depression leads to LV failure.
Okay, and for CPR?
Draw the modified CPR algorithm. It's the standard ACLS loop, but you add a big side box in bold red text, manual uterine displacement, and another one that says delivery by minute 5.
And that visual helps the examiner see your thought process so clearly. Finally, part 16. Summary and exam conclusion. Give me the elevator pitch to close out my long answer.
Okay. In conclusion, amniotic fluid embolism is an unpredictable, immune-mediated catastrophe characterized by the triad of hypoxia, hemodynamic collapse, and coagulopathy. Management rests on 3 pillars: rapid cardiopulmonary resuscitation with uterine displacement, aggressive treatment of coagulopathy with massive transfusion, and immediate delivery to facilitate maternal survival.
That is a 20-mark answer right there.
It is. And remember, in the Viva, your first word should always be call for help. It shows you are a safe doctor.
Professor, this has been an incredible review. I actually feel like I can walk into that exam hall and tackle this topic now.
You know the physiology, you know the protocols, just keep your cool, remember your ABCs, and you will pass.
To our listeners, especially those cramming for the Gujarat University exams, good luck. You have absolutely got this. We'll put a summary of the key points in the show notes for you.
And remember, these protocols save lives. This isn't just for the exam, it's for that one night on the labor ward when everything goes wrong.
Thanks for listening to The Deep Dive. We'll see you next time.